From MicrobeTV, this is Infectious Disease Puscast, episode 92, recorded on Monday, October 27, 2025. Hello, everyone. I'm Dr. Daniel Griffin, and joining me today is Dr. Sara Dong.
Hi, everyone. I'm Sara. Just got back from ID week not too long ago. So I thought I would just say thanks to everyone who came and said hi. I know, Daniel, they didn't get a chance to see you.
That's true. I'm a little jealous. How was it? How was ID week?
It was, it was good. I always love ID week. It's a bit busy because I think some folks know I help with coordinating the escape room. So that's always quite busy. But hopefully folks had a good time if they were able to come through and solve all the puzzles. But yeah. And then now I'm on service at the Children's Hospital. So I'm trying to plan my Halloween costume for Halloween day.
I'm still searching for ideas. What should I be, Sara? Do you have any ideas?
I don't have any ideas. I think I might jump on the train and just be Rumi from K-pop Demon Hunters. That's my tentative plan.
That's what my daughter, Eloise, is going to be. So I love that movie. I mean, it was one of those like, oh yeah, I'll watch that. And I'm like, I really like this. And then I realized I'm like listening to it while I'm going for runs.
Yeah. So I have a little jacket and I ordered the little purple thing that hopefully I can put a braid in my hair. We'll see how it goes. I have some backup plans if it doesn't work.
Maybe I could be from the dreamy boy band. I don't know.
Mm-hmm, exactly. Well, I could talk about K-pop Demon Hunters for a while, but I will switch us over. Welcome everybody to another Puscast. References, as always, are available in our show notes at MicrobeTV, the home of our growing multimedia empire. Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. Well, I'm pretty excited. We've got some great articles this week. I think we might, this might be a little longer than our usual, but it's going to be worth it. So remember to listen to TWIV, This Week in Virology, both my clinical updates and the deep dives. Got some great stuff. The article, Long-Term Clinical Immunologic and Viral Reservoir Outcomes in Children Treated with VRC01LS and 10-1074 monoclonal antibodies in the Tatalo study, was published in CID. Now, the title didn't really kind of get me, but then I dove into it. I'm like, oh, this is really cool. So, okay, if you've stayed long enough, the Tatalo study investigated dual broadly neutralizing antibodies as an alternative to standard antiretroviral treatment, ART, in children, right? Couldn't they have sort of done that a little bit better? Like broad neutralizing antibody as an alternative to antiretroviral treatment in children, right? That would have caught more people. So anyway, children received the BNAbs, the broadly neutralizing antibody only treatment for 24 weeks, or until detectable viremia equal to or greater than 400 copies per ml occurred, and were followed initially through 24 weeks after restarting ART. They continued follow-up from 24 to 96 weeks post broad neutralizing antibody intervention to identify long-term clinical, immunological, and viral reservoir outcomes. So these are little kids. Median age at the start of the follow-up was 4.9 and ranged 3.4 to 6.8 years of age, so little guys. From 23 to 43.6 weeks post-NAB intervention, all 25 children transitioned to dolutegravir-based ART. 12% had a single episode of HIV RNA greater than or equal to 40 copies per ml after starting the dolutegravir-based regimen, and resuppressed with adherence counseling on the same regimen. No grade 3 or 4 events, no children died, absolute CD4 cell counts remained stable at 96 weeks post BNAb intervention, and clinical biomarkers were stable. At last available sampling, 32% of the participants had detectable intact provirus. I should say only 32% had detectable intact provirus. With a low median HIV DNA and the PBMCs. They comment that this was safe and the level of virus suppression was high compared to most pediatric cohorts on ART.
Very cool.
Very
Well, I just have to give a shout out because I work with Roger Shapiro, who's the lead author on this. And of course, I know it involves tons of people through the Botswana Harvard Health Partnership. But anyways, very exciting.
Yes.
I have another HIV paper. This one was from JID, Resistance Analyses of Lenacapavir, M-tricytidine tenofovir alafenamide, and M-tricytidine tenofovir disoproxil fumarate in the PURPOSE 1 and 2 studies. And, I think we've brought these onto Puscast as they've popped up, but just in case, as a reminder, lenacapavir is an inhibitor of HIV-1 capsid function, and the PURPOSE trials looked at efficacy of lenacapavir in cisgender women, so PURPOSE 1, and then in cisgender men, transgender women, transgender men, and gender non-binary persons in PURPOSE 2, and demonstrated superiority of lenacapavir to these M-tricytidine tenofovir, so TAF or TDF combos. And so this is some published data on emergent drug resistance in the context of lenacapavir for PrEP. And authors found resistance to lenacapavir in 0 of the 2,134 participants in PURPOSE 1 and 2 of the 2,179 participants in PURPOSE 2. Both of those patients developed the N74D mutation. 4 participants in each study receiving lenacapavir were found to have unrecognized HIV at baseline. 4 of those total 8 participants developed this N74D mutation. In PURPOSE 1, 2 of 37 analyzed for resistance had M184I plus or minus K65R mutations. And then in the M-tricytidine TDF groups, the M184 MI or V was detected in 1 of 16 participants, so that's PURPOSE 1, and 1 of 9 participants in PURPOSE 2. So emergent lenacapavir resistance is overall quite rare, but it did occur among some participants with unrecognized HIV at baseline. And I think I just read off a bunch of numbers in an alphabet soup, I know, but if folks pull up the paper and look at figure 3, that's kind of a nice way to look at how the case numbers broke down as far as PURPOSE 1 versus PURPOSE 2, and they sort of map down as far as patients with baseline infections versus incident infections, and then the resistance noted there. So very cool and nice to have an update on this. And hopefully folks can check it out. I should have made it less alphabet soupy, but when you're reading it, it makes intuitive sense. But I think listening to it might be hard to just hear all the letters and numbers.
I guess it's, the takeaway, right? Highly efficacious. Resistance still looks to be rare. So encouraging. And one more, I don't know if we're going to have to learn N74D for the boards next time around, but maybe. So, all right.
Yeah.
The article, Susceptibility of Measles Virus to WHO Hand Rubs, Oral and Surface Disinfectants, published in Open Forum Infectious Disease. In this study, they tested virus inactivation by common oral rinses because primary transmission occurs via aerosols, droplets. They're also going to look at ethanol and propanol, hand rub formulations. And I really like this because they actually go ahead and they do this in cell culture. We've got TCIDs, so tissue culture, and some nice figures. What's funny too, like if you look at the figures, they're using Listerine Cool Mint Mild, Listerine Total Care, Meridol Gum Protection. I'm using actual products that are out there. But basically, what did they find? The hand rubs, the oral rinses, the surface, it all works. So, wash those hands, standard hygiene measures and infection control really make a difference. All right, and I've got another. We're going to sort of stacking on measles one after the other. This one is a take-home, Sarah. I think it's a take-home, right? Because if I ask people ahead of time, okay, so measles, what % of the time do people get measles without a rash, right? We say, well, you always get a rash. It may come a little bit later. Well, the article, Measles Without Rash During Acute Febrile Illness Surveillance in Tanzania 2023-2024. In this study, they enrolled 258 cases of acute fever, 48 controls admitted to one hospital in Tanzania for 1 year starting in February 2023. They're going to do blood culture. They're going to do PCR. They're going to do serology. The number one cause of fever is going to be measles, right? They're going to pick that up by PCR, serology. There's some other pathogens. But here's really the take home. Only 64% of the measles cases were clinically suspected, right? 30% did not have recorded rash. So 30% of the time, because little kids, highly contagious disease, no rash. So you're not going to think about it unless we really start, putting it up there and testing it. Could you imagine trying to request a measles test on a kid without a rash? Like, oh, but I just think. So.
Yeah. And then I think I'm wrapping up this section. I pulled this paper from CID, the 2025 Centers for Disease Control and Prevention Non-Occupational HIV Post-Exposure Prophylaxis Guidelines, Updated Regimens, and Remaining Questions. So this review highlights changes, as the title said, to the recently released CDC non-occupational HIV PEP guidelines, and sort of puts them in context of 2024 WHO guidance. I actually mentioned this original update back in May when it was released. But just as a quick review, some of the notable changes is that they updated their list of ART formulations to include Biktarvy as one of the options for preferred co-formulation for PEP. They recommended structured follow-ups at a minimum to include 24 hours, 4 to 6 weeks, and then 12 weeks after starting PEP. And just a little bit of additional guidance on the overlap of PEP and PrEP. And so the authors, talk about these new changes as a quick update, and then just kind of, put it in context as far as challenges that remain, including how the CDC guidance doesn't necessarily have a ton of information available to readers as far as alternative mechanisms to help us overcome provider, patient, or structural level barriers. And I think I didn't realize this. I guess the WHO guidelines have a bit more information about recommending delivery of PEP in community settings like pharmacies or police stations, other platforms, and then, some focus on it not necessarily having to be a certain specialist in ID or HIV. And then, they talk a bit about trauma-informed care and other novel forms of PEP for us to keep in mind. So I put the links both for this paper and then also the WHO guidance for everyone to take a look. But I thought it was a nice refresher and follow-up to something we had mentioned on Puscast previously. Cool. All right. And so that wraps up our viral section. We will move on to bacterial. Be sure to listen to This Week and Microbiology. I love a good ancient DNA and infection paper. I don't know where I saw this. I probably saw it on social media somewhere. So I pulled it from Current Biology, entitled Paratyphoid Fever and Relapsing Fever in 1812 Napoleon's Devastated Army. And so as you can tell from the title, this paper looked into responsible pathogens and the death of soldiers in the French army, I think as they were sort of retreating from Russia. They had DNA from teeth of 13 soldiers and confirmed the presence of Salmonella enterica, subspecies enterica, belonging to the lineage Paratyphi-C. So that's paratyphoid fever. And then they also found Borrelia recurrentis, which is responsible for relapsing fever transmitted by body lice. And I guess there have been previous papers that associated other pathogens, so Rickettsia prowazekii, the agent of typhus, and Bartonella quintana, the cause of trench fever. They didn't find any of that in this specific investigation, but I think obviously there's limitations to probably the sampling and being able to extract all the DNA from something from the 1800s. But I included some of the pictures and kind of the location of the site where they pulled these teeth and bone and DNA samples. So if people see these, they should send it to me because I feel like they always get published in these other kind of non-ID journals and easy to miss. So very cool.
This is kind of amazing photos. It looks like a mass grave there, right?
Yeah, it's pretty incredible.
Wow. Yeah, and miserable. I mean, that painting, I don't want to be part of that. That looks miserable. Freezing cold winter. All right. Well, it's a little disappointed with the results we've got here, but the article, Mass Administration of Azithromycin to Infants in Mali to Reduce Mortality, published in New England Journal of Medicine. So for background, and they give us this, we read that mass administration of azithromycin to children 1 to 59 months of age has been shown to reduce mortality among infants and children in this age group in some areas of sub-Saharan Africa. Now, prior work, right, the largest effects appeared to be among infants younger than 12 months of age within 3 months after treatment. And this observation motivated the design of this trial. So you're thinking, okay, this is really the high, the high impact group. Let's look specifically. So they do this. They randomly assigned villages in Mali, West Africa in a 3 to 4 to 2 ratio to receive distributions of placebo, azithromycin 2 times a year, or azithromycin 4 times a year. So infants 1 to 11 months of age received this weight-based dosing, and they're going to get them sort of different times of the year. The primary outcome was death within 3 months after eligibility had been confirmed, analyzed in the intent to treat. Among all the villages, 149,090 infants received at least 1 dose of placebo or azithromycin, so a total of 82,600 person-years of follow-up. We end up with 968 deaths. Mortality was 11.9 deaths per 1,000 person-years. In the control group, 11.8 in the twice yearly, 11.3 in the quarterly. So really not seeing any impact here. And I mean, they've got a nice sort of graphic where you can see, but really not seeing the impact we were hoping for. So a little bit disappointing there. All right, a couple more articles here in our bacterial. The article, Efficacy and Safety of Tedizolid in the Treatment of Acute Bacterial Skin and Skin Structure Infections, a systematic review and meta-analysis of randomized controlled trials, published in CMI. So they do that systemic review, PubMed, Web of Science, Cochrane Library. They're looking for randomized clinical trials comparing tedizolid with other antibiotics for, I love this, ABSSSI, acute bacterial skin and skin structure infections. All right, skin infections. So 6 RCTs. We ultimately end up looking at 2,277 patients. Tedizolid showed similar efficacy to that of comparators in terms of early clinical response at end of treatment, microbiological eradication. Overall adverse effects were comparable. But you end up with a few lower side effects with tedizolid. So lower risk of thrombocytopenia, so about 40% lower, neutropenia, relative risk 0.35, and GI disorders, relative risk 0.69. All right. The article, this I have to, I've always sort of thought about things, and then you read an article like this and you sort of want to whack yourself in the head. So, zoonotic E. coli and urinary tract infections in Southern California was published in Clinical Microbiology. So people always ask, oh, this E. coli, this urinary tract, where did I get it from? Like, oh, you got it from your GI tract. Well, people often don't ask, how did I get this in my GI tract? So it makes sense. Like, what is the next question? Well, maybe some of it might be coming from some animals, from zoonotic exposures. So they're going to estimate the proportion of UTIs attributable to zoonotic E. coli across 8 Southern California counties. So between 2017 and 2021, they collect 12,616 E. coli isolates from retail meat, 23,043 from UTI patients. They sequence a representative subset. Demographic, clinical, antimicrobial resistance profiles were compared between the meat isolates and the clinical isolates. Zoonotic, the XPEC, the E. coli strains, accounted for 18% of the UTIs overall, rising to 21.5% in high poverty neighborhoods. So sort of putting this all together, and they conclude that these findings underscore the contribution of zoonotic XPEC to the UTI burden in Southern California and the need for targeted interventions to reduce risk in vulnerable communities. So really a nice I guess one world, sort of realizing, that the animals have these E. coli isolates, and then maybe the animals have resistant isolates. Well, it's going to end up in us, and then it's going to end up really in us. So, all right. Now I think this will be like the teaching point. And so there's this article, Ceftonir versus cephalexin for the treatment of uncomplicated urinary tract infections, published in Open Forum, Infectious Disease. So I know many docs out there who are sort of like, Ceftonir, it's really like BID Keflex, BID cephalexin, right? I mean, no one can take a drug 4 times a day. Well, this study makes clear that it's not. So they're looking at 367 patients, end up, about half in each group. Patients treated with ceftonir experienced a significantly higher rate of treatment failure, basically twice the treatment failure, 23.4 versus 12.4. So really independently associated with treatment failure, twice as likely to fail. They point out that due to its low bioavailability, poor urinary penetration, there are concerns that ceftonir is a suboptimal agent for the treatment of UTIs.
I don't think I ever reached for ceftonir for UTI. I mean, this is a good reinforcement of that. And I also think they may have presented on this at ID Week as well.
I hope so, because a lot of urgent cares, like this is like, no one can take Keflex, so we'll give this. It's twice a day. It's so much easier. But it's going to fail twice as often.
Yeah, interesting.
Yeah.
All right. Well, I have one paper for our fungal section today. This is from the Journal of Antimicrobial Chemotherapy. Antagonistic in vitro interaction between alorifim and voriconazole against Aspergillus fumigatus. And so, as you can guess from the title, this study observed antagonism for 56% of isolates based on a liquid microdilution checkerboard assay, which included 32 clinical isolates, 27 were VORI susceptible, 5 were VORI resistant. They observed antagonism for 75% of isolates based on a different method, this response surface analysis. And they really found antagonistic interactions consistently across all tested isolates and agar configurations. So basically this in vitro antagonism between alorifim and VORI in both azole susceptible and azole resistant isolates. So I pulled some pictures. Their first 2 figures are looking at this little sort of heat map, antagonism versus synergy with alorifim and VORI against azole susceptible Aspergillus, and then the figure 2 was azole resistant Aspergillus fumigatus. And then you can also see in some images as well that they have this decreased zone of clearance around alorifim in presence of VORI in vitro. And so I went ahead and just pulled this directly from the paper rather than trying to paraphrase. The antagonism observed between alorifim and voriconazole may be explained by the impact of azoles on fungal metabolism, particularly the upregulation of the pyrimidine biosynthesis pathways. So azoles inhibit ergosterol synthesis, leading to a cellular stress response in Aspergillus, and that can enhance the activity of pathways involved in nucleotide production, including pyrimidine biosynthesis. And since alorifim targets dihydroorotate dehydrogenase, a key enzyme in this pathway, the increased flux through pyrimidine biosynthesis could diminish the drug's efficacy. And so this metabolic compensation likely contributes to reduced susceptibility to alorifim observed when combined with azoles. So this is in vitro, but something for us to think about as we hopefully get more access to drugs like alorifim. And just as a little nugget for those who did the escape room this year, I did a puzzle. It was like people had to solve the mechanism of actions for different antifungals, and these were on there. So hopefully it doesn't scar people too much if they didn't get that puzzle. But we always think of these as, they're different pathways, but something to keep in mind in the future and for us to be on the lookout for.
All right, I love these figures. These are great. All right, parasitic. You're going to have to go to This Week in Parasitism. There's nothing here this week, but we did recently do a great. It hasn't dropped yet, so it's still out there. But looking at Cryptosporidium and using CRISPR and Cre-Lox and all kinds of other things to understand how we might target that in the future. Just really an important pathogen. If you read the GEMS papers, where we realize it's really a huge problem with childhood diarrhea throughout the world. But all right, miscellaneous. We got a bunch here, actually. And we'll start off with a catchy title. I thought you might have noticed this one. Carb Enthusiasm. Did you like that, Sarah?
Yeah, I did.
An ethics-informed analysis for clinicians of the U.S. National Action Plan for Combating Antibiotic Resistance Bacteria, published in CID. So there is a lot here, but I did want to highlight what I think is the point of all this. We read, antibacterial resistance is an inherently ethical issue. Antibiotics are the only class of medications that generate a loss of effectiveness with consumption over time at both individual and population-based levels. This progressive exhaustion of existing treatment options presents a distributive dilemma in clinical medicine regarding how to fairly allocate antibiotics within individual patient care while protecting the community and future generations from worsening ABR. I was talking about this in rounds this morning, and it was an individual who was in the ICU again, another episode of sepsis, and just talking about how, the goal is for this patient to survive, this patient to end up back out in the world. So, that world is this world we're creating with maybe overuse of antibiotics, maybe. And all the antimicrobial resistance. And not only is this person now going to come in the next time with their sepsis in that world that we are creating, but they themselves are potentially going to be a victim directly of their own microbiome being pushed towards the antimicrobial resistance apocalypse.
All right. And then I lost my track. Okay, so I pulled technically two papers from CID, but it's a review article called Infection Control in Carceral Facilities and an editorial commentary that was paired with it, Infection Prevention and Control in Carceral Settings. There's so much covered in this article, and I kind of knew I couldn't do it justice quickly, but I just wanted to highlight for people to check out. The authors here talk a lot about what has changed in recent decades. Some things that I learned as far as timing is that prisons developed shortly after the American Revolution, and the sort of federal prison system as we think of it more so today was probably from sort of the 1890s. But then when we think about infection prevention and control, a lot of what we're doing these days has been even as recently implemented as the 1970s. And so there's a prior review from 2007 on infection prevention control in these settings. But of course, there's been tons of changes, which are led primarily by things that we've learned from COVID, of course, but also using technology, such as helping with outbreak investigations or providing access to providers or clinicians, how they have used wastewater surveillance and others. And so the authors kind of break it up into various buckets like respiratory virus prevention, bloodborne infection, STIs, vaccines, PEP. There are, of course, tons of brilliant tables and figures. I think I pulled a handful. Yeah, this first one was table 4, was their key components for prevention of respiratory illnesses. The second one I have here is a figure related to facilities and cleaning agents. So just like a tour de force walking through tons of different topics, but I learned a lot and just wanted to point that out in hopes that people will take a look and read it.
Do you like the yellow gloves they've got in that graphic there?
Mm-hmm. Steady up.
All right, so I'm going to finish us off with an interesting article that I think has gotten a lot of play in the press. And so this is the article, SARS-CoV-2 mRNA vaccines sensitize tumors to immune checkpoint blockade, published in Nature. So I'm going to have a little background and even a little more background. So why do they even look at this? And so, there's a lot of this misinformation out there about these turbo cancers and all these horrible things that the mRNA vaccines have done. But actually, one of the things they noticed is certain individuals would get their mRNA vaccine, and then their tumor would just melt away. They'd be cured. And they're like, that's a little odd. What's going on here? So it takes a little background because we're going to understand something about immune checkpoint therapy and immune evasion and all the rest. And don't worry, I'm going to cover this on the clinical update, and I'm going to link to a really nice deep dive that was done on the TWIV that dropped on Sunday. So a little background so we get the punchline here. So they found that getting a COVID-19 mRNA vaccine within 100 days of initiation of a certain type of cancer therapy that we're going to walk through in a moment was basically improving your odds of surviving. So basically being alive at 3 years, almost twice as likely. So from a 30.8% up to a 55.7. And as far as what was the average survival in some of these tumors where people were not surviving, they were giving people almost twice as long, going from 20.6 to 30.73 just by getting a COVID shot. So what is going on here? So what type of cancer therapy? We'll start there. So there's a certain type of cancer therapy that people might know as immune therapy, right? And so this is a type of therapy, immune checkpoint therapy. So the idea is people get cancer, and we've got our immune system that is actually going to theoretically jump in and detect that tumor and get rid of it. But tumors somehow have the ability to put brakes on that immune activation from going in. So there's several steps that need to happen before a cancer spreads and potentially kills us. And sort of right there in the middle of the progression is this immune evasion. So what the cancer cells will do, I'm going to leave a link into a paper I wrote sort of walking through that in detail, but cancer cells will actually put proteins on their surface. Like, for instance, they might express something called PD-L1. Maybe some of our listeners are familiar with that. And what happens is the T cell comes along with a receptor. The cancer cell gets the message, oh no, don't attack me. Please go kill yourself instead. Or the cancer might have a certain protein, CTLA4, on the surface that tells the C cell, nope, nothing to see here. Why don't you go ahead and take a nap? So instead of the T cells killing the tumor, they're all reading Sylvia Plath poems and committing suicide or sleeping next to the pool. Now, what we do is we give our patients certain drugs that cap those proteins. And then when the T cells come in, the cancers can't send this information to our T cells. But we're seeing here that if you give a COVID shot, those immune, the ICIs they call them, these immune therapies are basically working twice as well. And they really, not only do they show us that this is happening, that people are living twice as long, that they're twice as likely not to die from the cancer. But they actually they go into mice and they figure out that there's this mechanism with interferon signaling. And then they go back into people and they find that, boy, the mRNA that's in the Moderna might be even a little bit better than the Pfizer because it's a little bit stronger. And then maybe if they make it a little less tolerable by those famous Carico modifications by taking those out. So really exciting because actually what we're really seeing here is that the mRNA vaccines, rather than causing turbo cancers, are actually doubling the ability of some of these effective therapies to treat cancers.
Very cool. And I added one thing last minute because I did read it and I forgot to add it to the podcast. There was one of the CID, I forget what, I think it's Voices of ID is the category, but there's one called Infected with the Academic Bug that was released in one of the most recent pushes, I think, of online access to articles. And it's really funny and well written. And it makes this metaphor of kind of overworked academics as having an infection or being infected. And just kind of draws that out as far as, I pulled one quote. They say, "We learn to live with the chronic infection. Anecdotal evidence suggests that hobbies and perspective may reduce symptom burden. Sometimes it helps to remind ourselves that the real goal isn't the H index or the top tier publications or our egos. It's the science that actually matters." Come on, that's what really matters, right? So I hope people have already read it, but I really enjoyed it. So I thought I would throw that in there. And so on that note, that brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher, or on YouTube, where you can subscribe, like us, ring the bell, leave comments. We love to get your questions, comments, paper suggestions, so send them to puscast@microbe.tv. And if you like what we do, or you just want us to keep doing it, consider supporting the science shows of MicrobeTV at microbe.tv/contribute, or Parasites Without Borders at parasiteswithoutborders.com, and click on the donate button.
I'm Sara Dong. You can find me on Blue Sky at Sara Wynn Dong or at febralpodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.